Hi, everyone, and thanks for joining us for this session, Reimbursement 2020, What a Year, presented by CAHF team members Jeff Sandman and Jennifer Breen.
Good afternoon and welcome to today's Reimbursement 2020, What a Year. Today I have with me Jeff Sandman, our Director of Reimbursement with CAHF, and I'm Jennifer Breen, the Assistant Director of Reimbursement with CAHF. We're pleased to bring you an update about all of the reimbursement happenings in 2020 and the impact that it's going to have on your facilities going forward. Next slide. So we've broken this topics into a few different chunks. The first two chunks we're going to talk about are the renewed AB 1629 rate setting system and QASP updates, which are regular kind of topics that we would normally be talking about this time of year. Obviously, we've been working on the AB 1629 updates for quite some time now, but again, COVID has thrown a wrench into everything. So I'm going to discuss with you early on about the AB 1629 updates and the QASP updates. And then we're going to switch over to Jeff, who's going to talk about the COVID impacts and the impact it's going to have on auditing and reporting for your facilities. Next slide. So this is an overall timeline of our 2020 reimbursements. Back in January, we were at a point where the governor's budget proposal, we had a framework of a renewal for the AB 1629 rate setting system outlined, and we were moving forward with that framework. The governor and his staff were working on updating the trailer bill language and getting that detail out on a 4-year-long deal. What happened in March was COVID really hit the United States, and the pandemic hit, and it was about the same time as our AB 1629 panel at the spring conference, which we had to transition last minute into a remote setting. So from that time period on, we have been in this COVID crisis mode. However, we have pushed through and gotten an AB 1629 extension, albeit a shorter extension than our projected extension back there at the January budget proposal. In May, the Department of Finance posted the trailer bill language, and the updated language was approved in June. Trailer bills were signed, and the AB 1629 rate setting system came into effect starting August 1st. We go on to the next slide. We have a basis. We have the basics of the AB 1629 rate setting system outlined. The predetermined audited cost-based rates are how our rates are set. And what that means is that your audited cost rate-based rates are set based on adjustments, or set based on your actual audited costs with assumed adjustments for inflation and add-ons. The state of California's AB 1629 rate setting system included a 7-peer group breakout of the state, in which those peer groups would have capped your various labor component costs, such as your labor, direct labor, non-labor, PLI, and administrative caps. The way that these caps work in the AB 1629 system is that within that peer group, you're arrayed out the highest to the lowest in the per diem cost-based system for those different cost buckets. In your peer group, that 90th percentile person is found, and whatever their cost was for labor becomes the cap. So if you're above that cost, you're brought down to that cap. This AB 1629 system had many extensions since inception. The most recent one was a prior 5-year extension, which obviously ended on July 31st, 2020. And our basic rate setting system had been an August through July system, which had the rates set based not even on the state fiscal year, but on an alternate fiscal year. Next slide, please. In addition to the caps I mentioned above about the peer group caps, we also have the budgetary caps and the shave. The budgetary cap is to limit the risk to the California State General Fund. And so they state our annual rate increases in terms of the increase in the weighted average Medi-Cal reimbursement. So you can see here, this is the old language, but you can see here that the language said that the rate increase shall be, the increase in the weighted average Medi-Cal rate shall be 3.62%. Now, as we talked about before, it's based on your audited costs. So what does this 3.62% really mean? Next slide. What it really means is the adjustment is how they calculate the adjustment factor for what we call the shave. So under the AB 1629 system, every facility individual rate is calculated, and the overall weighted average rate is calculated. And so the top line here would be every facility's AB 1629 rate averaged out, weighted by their Medi-Cal days. And the next line, the 211.60, that would have been the prior year's weighted average rate, adjusted for new mandates and adjusted for the updates in QASP and licensing fees. So you can see that's 211.60. And then they determine the limit based on adding 3.62% to that 211.60. So now we're at 219.26. So in this example, the adjustment percentage, or what we call the shave, is 3%, or the percentage applied to the rates is 96.7%. And what that is the limit, the state's limit on its budgetary constraint is 219.26 for the weighted average Medi-Cal days. So they shaved 226.54 by 3% to get down to that 219.26 figure. So that adjustment is applied to all the individual Medi-Cal day or Medi-Cal facility rates for that time period. And this is a very big issue, and this is where CAHF really spends the majority of the time advocating, is trying to make sure that adjustment percentage, the adjustment percentage is the lowest it can be, and that the percentage that you get encompassing your rates is the highest. The next slide shows a graph, the next slide shows the details on the AB 1629 renewal. So as I mentioned, the AB 1629 renewal was a shorter period renewal than we originally envisioned. Originally envisioned was a renewal through 2024. Due to the budgetary constraints, due to a lot of uncertainty, due to COVID, it was adjusted down to being a shorter period, only through 2022. One of the big changes in the AB 1629 renewal is transitioning our rate year from that alternate rate year, the August through July rate year, to a calendar rate year. This had to do with setting up for CalAIM, which was where the state wants to encompass all of long-term care support services, including skilled nursing, in managed care. So what they wanted to do is make sure that the rate system's year aligned with the capitation year for managed care plans. So here we have a conundrum, because our rate system ended July 31st. So we have a short period transition, and that's this August through December rates. So these August through December rates reuse the 2017 audited cost reports for rate setting. These rates also did an update for the peer group capping, or for the peer groups by which they break the state up for capping. We'll talk about that in a little bit, but we went from 7 to 11 peer groups. They also updated the percentiles for those cappings. So we went from a 90th percentile for direct and indirect labor costs to a 95th percentile for direct and indirect labor costs. And we also received a 3.62 increase to the weighted average Medi-Cal rates. Going forward for this short deal we have through 2022, we have 2021, where we'll move on to the next year of audited data, so the 2018 audited data, a 3.5% increase in the weighted average Medi-Cal rate. And again, we're going to maintain that standard QASP program in that year. And the next year, January through December 2022, this is the first year that would have been significantly changed had the proposed updates been enacted, but that were not enacted due to COVID and the lack of capacity to actually for the state to go through and try to make those changes at that time. But the state ultimately wanted to transition QASP from being a lump sum payment every April to being embedded within the rate system. So part of your stated rate would be based on your quality-based metrics. And in that system, what we would have had would have been about a 4% increase. 2.25% would have been towards the regular base weighted average base rate, and then the rest would be towards the quality portion of that. Because the quality side, the quality transition kind of got cut up to the wayside for a bit, what's happening is that we're getting the 2.4% to the base, but we do retain the QASP for another year beyond what was already enacted. And so we have that additional time period for the QASP funding. Next slide, please. So some additional changes to the AB 1629 system that came about in the budget revise and in the trailer bills in AB 81 was that the state is adamant that it needs the ability and it has the right to collect the quality assurance fees from various provider groups. And so they've strengthened their language on that. They've included penalties and interest. They've included language to allow them to collect from related organizations. And this is probably one of the biggest changes that they've made. And this is going to be one of the ones where facilities may start seeing collections if they are in a corporate setting or in a chain ownership, where there may be a facility that significantly in arrears that does not have significant fee-for-service Medicaid that might have that collected from another related facility. And also it strengthens and creates limitations and changes of ownership for facilities that have outstanding QACs, making sure that the people acquiring new facilities and people acquiring new facilities don't have outstanding QACs, or if they do, that they're in repayment plans and that they're making good faith efforts towards that. Another part of AB 81 is that the rate increases are dependent on COVID-19 compliance and related requirements. So this is an element that was put into the language. And what this really says is that you need to have good faith efforts to meet the ASLs and the mitigation plans for that. And what has happened, and the state still has not given us a firm guideline. What we understand they are looking at is really infection control preventionist compliance with a lot of those programs and good faith efforts towards that in determining whether or not you'll be eligible for, again, the weighted average increase in the Medicaid rate. So, there's kind of actually more than two parts to your Medicaid rate change. you have your audit-based cost change, you have your add-ons and inflationary changes, and then you have the weighted average change, which is what really determines that overall shave, which reduces your rate. Additional changes to the AB 1629 rate setting system was that they allowed for 1 day of noncompliance with staffing audits to have an appeal right. If you remember previously, if you only got cited for 1 day of noncompliance with the staffing audit, you did not get fined specifically from CDPH. However, you would lose your QASP award had you qualified. CDPH said that when appealing those 1 day citations, that facilities did not have standing because they did not get directly penalized by CDPH. However, they did lose their QASP. This fight has been fought out before legally, and providers did prevail in as far as getting that 1 day of right through legal appeals. But now what this says is, yes, you do have an appeal right for 1 day of noncompliance with the staffing audits, and we are happy for that. There's also a hold harmless provision for the change in peer groups, and we'll talk about the changes in peer groups a little bit later, but it's hold harmless so that changes in moving from one peer group to another, where now you may not be in a cap, you might be capped in the new peer group that you weren't previously capped in the old peer group, those changes you have been held harmless for. Another thing that we do like is that the pediatric subacutes were excluded from the QASP quality assurance fee, as well as the QASP. They had never previously been included in QASP. However, they service a different population, and it's a different system, and they have a different payment system, and they've not really benefited from the AB 1629 system. So they've been removed from the QASP and QASP. However, something that CAHF is not as happy about is the SNF STP has been excluded from QASP. This is a small subset of providers who are SNF providers that have a specialty treatment mental health program. And what has happened is that those STP days are on a different line, or could be on a different line if their cost report or their audit report, and they did not get picked up from QASP historically. These days are paid on the AB 1629 rate system, are included in the quality metrics used to determine compliance with QASP. And we don't see any reason that this should be excluded from QASP. However, the state has kind of gone back in and stated that they're excluding those days from QASP. It is, again, a special situation, and I believe that we do know all the providers who are affected by this, and they are working with legal representation, and more might come from that. Next slide, please. So beginning in 2021, there's also additional fines and penalties for non-compliance with staffing audit, as well as non-compliance with minimum wages and Medi-Cal minimum wage pass-throughs. These are the Medi-Cal minimum wages. These are the incremental adjustments to the minimum wage that you have to pay for all of your staff in the buildings. So all your non-administrative staff, and then there's different wages for your CNAs, et cetera. If you're not complying with those pass-throughs, you're not complying with the state minimum wage requirements or 3524, you could be fined up to $50,000 per month if out of compliance. And the annual limit for that is 4% of your Medi-Cal revenue based on the prior year. Now, this is compliance with the state minimum wage and Medi-Cal pass-throughs. It's important to note that local minimum wages have not been supported by Medi-Cal rates. You must comply with your local minimum wage. However, if your local minimum wage is already above what the state minimum wage plus the Medi-Cal pass-through is, you can just pay the local minimum wage. You don't have to pay any pass-through. So it's just the state minimum wage and the pass-through that you need to be compliant with, as well as your local minimum wages. Obviously, you have to comply with your local minimum wage, but this requirement is the state minimum wage and the Medi-Cal pass-through. A big piece of this that Jeff will talk about later is that there's also a requirement, a stated requirement in the legislation requiring that the state audit the expenses and revenues associated with COVID-19 increase and other funding. So what that requirement in AB 81 is saying is that the state will audit all of the facilities for their 10% increase, at least for all of the skilled nursing facilities. ICSDD providers are not necessarily encompassed within AB 81. However, the state has the right to certainly audit those ICSDD providers as well. However, this requirement here is directed towards the SNF. Next slide. So this next slide shows us the updated peer groups. Remember I said we went from 7 to 11 peer groups? So this slide gives us a breakdown of those peer groups. You can see the different colorings correspond with different peer group numbers. This was determined based on an analysis done by DHCS, based grouping counties with similar direct and indirect labor cost structures, like their per diems, and had similar median and distributions within the counties. And aiming at trying to make sure that the peer groups all have roughly the same number of facilities in them. If you knew about the prior system, you might have known that there were some peer groups that had a lot of facilities, 300 facilities, and some that had very few facilities, like 20 facilities. And it was a very kind of skewed thing. So another issue though with the state of California is that Los Angeles County, as one county, has 300 facilities. So what they did is they split LA into 3 peer groups. So the next slide shows the 3 peer groups that LA County has been split into. LA County's peer group split is based on the CDPH district offices. So it's roughly geographic within the county. And they correspond to peer group 1 being LA District Office 1, peer group 2, peer group 10 being District Office 2, and peer group 11 being District Office 3. Next slide. This slide and the next one just show the estimated annual impact of the change in peer groups. And this is an analysis that CAHF did based on the change in peer groups using the 1920 rate setting system. And so you can see for the new peer groups, you can see what counties are under them and what kind of change they had. A big change that, one of the biggest changes to note is that in this updated peer group system, Alameda and San Francisco counties have been grouped together as one peer group. And that means that they have left the peer groups and that they had used to be in. So there's some push and pull with that. And you see on the next slide, you can see Sacramento, or maybe you can't. Well, you can see some of the counties that had some of the negative consequences of this change. So you can see counties such as maybe Riverside and San Bernardino that had maybe a more negative effect. However, as I mentioned before, you have a hold harmless for the change in the peer groups, and basically a hold harmless that your rate would not go down due to these changes. Next slide. So this is just a handy list for the August to December peer group rates. These are the peer group caps for all of the 11 peer groups. So remember, the one change that we had was that the direct and indirect labor for all the peer groups went to the 95th percentile. And obviously the 11 peer groups obviously changed themselves. So you can see here what the cap with the highest amount for that cost component can be within those peer groups. Next slide. And here is the slide that shows how that budgetary adjustment has changed over time. Remember when we talked about the shave or the budgetary adjustment, the overall program cap? And so this is all about the change in the weighted average Medi-Cal rate that we negotiate with the state. And what that affects is the amount of the rate that we basically get to have, which is our budgetary adjustment. So you can see here, the prior 5-year deal had been based on this assumed notion of 3.62% per year, which would bring us from being about a 7% shave, which means that in 13-14, we only got 93% of our AB 1629 rates. We got 93% of them, to bring those up to pretty much 100%, assuming a 2% inflation adjustment as well as 1.62% cost adjustment over that 5 years to bring you up to, 2% inflation adjustment and 1.62% to bring you up to the full cost within that time period. And that deal worked for a good few years, and you can see that we got almost there, 99% or so in 16-17, and then we started seeing our actual costs outstripping our assumed inflation and cost growth. And so that's where we came to at the end of the 19-20 rate period, the end of the 3.62 era. And so what we have right now is we have this August through December rate, which again is a 3.62% update, but we had some of those changes embedded in it, and we had the, I guess you could say, luxury that we stayed with the 2017 cost reports to set that. So we were able to inflect that curve and start going back into a good direction to capture more of our AB 1629 rates and lose less of it to the shave. Next slide. This slide just shows the overall weighted average peer group averages for all 11 peer groups. This is a handy slide, especially if you want to kind of see where within that peer group, what about the average is. The first column includes for facilities including the QAF. The second is without the QAF. Only some facilities, certain nonprofit facilities and certain government-owned facilities don't pay the QAF. Next slide. So the overall impact on rates that this deal has done is that we have about a $90 million rate increase for the August through December rates. So that was about $90 million more in August and December than we would have had based on the prior rates. And we have about a $900 million rate increase, about almost $1 billion rate increase through 2022. Overall, facilities for the August through December rate setting, we talk about the 3.62%, but their actual average increase was closer to a 4.4% increase if they were a regular facility. CHOW facilities, however, and CHOW means change of ownership, and these facilities don't have a change in ownership, which basically has them frozen at their prior owner's rate, adjusted for inflation and mandates. And so those rates were only increased about 1.7%, because when facilities sit in that change of ownership rate setting, they're not really seeing the benefit of that change in the increased weighted average of the Medi-Cal rate. Next slide, please. So our August through December rates we talked about already a little bit. So again, 3.62% increase. The QAF, the quality assurance fee amount, is the same as 2019-20 rates. The hold harmless is in effect. The published rates, this is an interesting point that facilities should know. The published rates on the website include your COVID 10% adjustments. They don't specifically state what your rate is before the 10% adjustment, but what you can do is you can back into that number and just remember that the 10% increase is based on your 19-20 rate. So you can look at what your 19-20 rate was before COVID and what it was after COVID. You can find what that 10% amount was, and that will be that delta, that's your 10% increase. And you can take that amount and then back out of the published rate to get to your base rate. However, the August-December rate, you are going to not have to worry about that because the PHE has been extended past December. So those rates, there won't be another publishing of the non-COVID rate because it will be COVID period, that whole rate period. An EPC is being processed, and I did see an EPC letter on the website saying that the processing is beginning October 22nd for positive payments, and then in November for negative payments. There should not be negative payments. And so that's in the works. I have not had confirmation yet that facilities have received that. However, look at your RAs and you should see those funds coming for the August-December retro rate increase. Next slide, please. 2021 rates. Yay, it's another year. So this is going to be our first year of the calendar year rate setting. This is exciting. Again, we're going to be using the 2018 audited cost data. We have a 3.5% increase in Medi-Cal weighted average. Add-ons so far are about $250, $249 for minimum wage. A lot of our other add-ons expired. And because, remember, we're using old cost reports to set future rates, we get the add-ons for new state and federal mandates. So those old add-ons expired because now we have a new cost report, a new audit report being used to set the base where the costs of those mandates have been incorporated. The QAS, we don't know the final QAS for 2021 yet. However, we do have an estimate, and it's 1519. It's actually a slight decrease from the current QAS, which likely has to do with the fact that the licensing fees always are increasing. Next slide, please. Okay, now we're going to talk about QASP. So QASP is the Quality Accountability Supplemental Payment Program. As you all know, QASP is paid out every April based on the prior state fiscal year's performance in a variety of metrics, and you're rate out based on the 75th percentile in the state's performance and the 50th percentile of the state's performance. So if we go to the next slide, what we can see is that there was a payment recalculation done for the April 2020 QASP payment. And so what happened was that once the QASP payments started coming out, CAHF members started noting significant variances between their initial tracking and the QASP data. And so that kind of started hitting some flags. Other members had been disqualified from QASP altogether due to data completeness issues. And there is a data completeness standard. You have to have 85 or 90% of your data submitted timely so that they can draw the data, etc. And so we started working with CDPH and HSAG, and we found out that they had deviated from their normal data collection policy for the program. And so what they did was, without notifying the industry, is they basically used the wrong time, not wrong time periods, but they took the snapshots at the wrong times. And so facilities that might have had corrections or had, if they took that quarter snapshot and then after that cutoff that they took the snapshot, something changed, it was never incorporated. And so CAHF went back to the CDPH and requested that they rerun the QASP data using the correct collection policy, which is having them collect the data for that prior year as of September. And so what this did was it kind of shook up QASP. And we can see on the next slide how some of these metrics have changed. So, we shook up QASP. So now different facilities are qualifying at different amounts because there's different NDSs in the mix, or things were corrected or changed or whatever. And so what we see is that some of these metrics, some of the percentiles to the 75th and 50th percentile changed. You can see here how those have changed. Notably, antipsychotic medications dropped fairly significantly. Flu shots and vaccinations went up. As people went through and they did their routine quarterly checking and corrections within their MDSOs. And so what this did was different facilities may have qualified in the original payment and subsequently qualified at a lower tier or not qualified at all. Other changes made also were facilities that had A or double A citations that had them appealed and they won their appeals could have them retroactively get requalified for the cost. So they got requalified during this process. And facilities that subsequently had A or double A citations during that period that came out might be retroactively disqualified. So there's a bunch of shakeup that happened in QASP. And this ultimately changed the per patient day payments that happen for QASP. And the next slide shows how much each per patient day QASP payment would receive based on their tiered system. So tier 1 is you did not qualify for QASP, you had under 50 points. No change there. Tier 2 went down from $8.92 to $8.56. And similarly, tier 3 and the improvement payments also went down. So even if you stayed within the same QASP tier, your payment was reduced slightly due to this shakeup. There's some other things that we should mention about QASP that we're looking into. So QASP, obviously, we talked about earlier, the state wanted to redesign QASP and transition it in a future rate setting system so that it was more a part of their your facilities based rates rather than the supplemental payment. Another thing is the supplemental payment pool is typically, we say it's $90 million pool. Well, that pool's kind of been shrinking, and so it's been chipped away. And the big chip away is programmatic costs for CDPH to run the program and the interagency agreement, as well as the withholds, or sorry, not withholds, but the holdback that the state does to hold back reserves for correcting QASP errors in the future. And this is, we can blame Jeff Sandman for that directly because, we started finding QASP errors and we went back to the state and said, hey, you forgot these days, these are managed care days, you forgot them. You should just pay me for them. Okay. So the state pays out and now they have to withhold from the next payment pool to kind of pay back those other withholds. So it's all kind of a complicated financial thing, but what that ultimately is doing is it's reducing the total pot of funds. And so the next QASP payment we're seeing now from DHCS is that the total QASP pool would only be about $81 million, and then that would be reduced related to their withholds on the for future payments. Next slide. And with that, I'm going to hand it over to Jeff to talk about COVID-19 and what's happened as far as COVID-19 goes and how that's going to impact auditing and cost reporting going forward.
Hi, everybody. If it wasn't enough that we had a full-on reauthorization of AB 1629, COVID-19 hit. And when COVID-19 hit, it became a significant problem for everybody. So when you start going through, we're going to go through a few things. I'm going to go through this rather quickly because we only have a certain amount of time left on our dial here. Next. Okay, so beginning in March, when everybody ran home and hid, they had a lot of different activities that occurred because of the Families First Coronavirus Act, commonly called the CARES Act. There was Medicare accelerated payments where people received 6.2% of their Medicare payments in advance for a couple of months there. There was employer tax deferrals where they didn't have to pay certain employer taxes until the subsequent year. And of course, there was a 6.2% FMAP increase to states. All of that assisted everybody in being able to receive additional funding into the program. In addition to that, just to give you the magnitude of it, we can start to look at the SBA Payroll Protection Program. The SBA Payroll Protection Program obviously put a lot of money into the system and gave the ability of providers to either have a very inexpensive loan going forward for a period of between 2 and 5 years. And in addition to that, it allowed them to forgive certain expenditures, most importantly, payroll pieces if they kept people employed during the pandemic. So that was an important piece. And then the Health and Human Services CARE Act Provider Relief Funds. They are basically delineated into several different sections. There are general distributions. There's been 3 different distributions there. And there have been targeted distributions specifically to skilled nursing facilities. And we've had a couple of those there. And we're currently in an incentive payment piece as we go forward now into the future. So the first thing is in the general distribution, the overall goal was to pay everybody 2% of their net inpatient revenues as reflected on your 2018 Medicare cost report. And if you go to somewhere down the line, I forget what number of pages is back there, you can see that number. But the first tranche, what they did is they wanted to get money out there quick. So the only way they could get money out there quick is they gave 6.9% of the Medicare fee-for-service annual billing. And then they did a true-up in the second tranche of the first general distribution, where they looked at what a provider received. If they already received 2% of their money, as far as the 2% net patient revenue standard, they didn't get any more. If they received less, they trued that up. And then there was another tranche, which was the Medicare CHIP tranche, which is basically for all the other providers, they could receive up to 2% of their net patient revenue. Okay, next. Okay, skilled nursing targeted distributions. These were the most important, of course, to our industry. There's a $4.9 billion distribution to all the facilities in the United States. And in this distribution, there was a $50,000 per facility up front and $2,500 per bed. The second targeted distribution was another $2.5 billion, and that was $10,000 per facility plus $1,450 per bed. And you move on to next. And then we have the incentive payment scenario here, where over the next 5 total, there's going to be 5 total payments. The first payments, we understand, recently just went out. So people should start seeing those in their bank accounts. And they range anywhere from, I want to say, $12,000 or $13,000 to roughly $36,000 per facility. And you have to demonstrate good infection control and mortality outcomes. You first must meet a set of gateway criteria, which means you have an infection rate must be less than the county they reside in, and they must have a COVID death rate less than the nationally established benchmark. Okay, next slide. Okay, these are just the tentative payment dates associated with the first 4 payments. And then, of course, there's going to be aggregate catch-all payment in February of 2021. Okay, next slide. Okay, so when you look at the infection control measure, 80% of those payments are going to be based on the infection control measure, and 20% of those payments are going to go to the mortality measure. Okay, next slide. Okay, so when we start looking at this, CAHF decided that we were going to put together a group of providers to provide data on increasing costs due to COVID because of all this that occurred. And we went to the department and we advocated really hard. And early data showed a 5 or 6% increase in April, even in facilities without COVID. And because of that data, CAHF was able to get a 10% add-on rate increase, retroactive back to the start of the pandemic and going forward until the federally declared disaster is abated. And so far that's 120 so or whatever it is of January, probably will go farther than that. So those rates will be in effect for at least that period of time. Okay, so SNFs and ICFD-DDs are experiencing those costs, and those people are all receiving those increased rates. Okay, so stopping here for just a second, you can see the large amount of money that went out. If you add all that together, you're talking close to $1 million a facility on all the CARES Act stuff. And you're talking about $55 million a month for the 10% add-on in the Medicaid rate. So there's a huge amount of money that went out there in the last 7.5 months. Okay, next slide. And here's where Jennifer was talking about earlier. And this is the part that gives us a lot of fright. Is the department's going to audit those costs and revenues associated with skilled nursing facilities that are associated with the COVID-19 public health emergency. What this means is they're going to bring the Audits and Investigations Division in of Department of Healthcare Services, and they're going to be given a fairly good scrub of that money. So it's very important for providers to put together their information and support that. Okay, the next slide. These are some of the expenditures that we deem as allowable for COVID-19 costs. So what CAHF has done is CAHF is meeting every Monday. We have a Zoom call, and we've got several different people coming in and out of there trying to determine the operational changes that have occurred in skilled nursing facilities since the start of the pandemic. And then trying to associate that with the driver, which is of course the costs, and try to determine some sort of a number that when we go forward and we're audited by God knows how many different types of organizations. On the federal side, you could have CMS and their contractors, you could have the Office of the Inspector General, you could have the MAC, and on the state side, of course, you could have the Audits and Investigations Division, more specifically the Financial Audits Branch, all coming out to review these costs, these terms and conditions. So one thing we want to make sure that people understand is understand where the website is go out to, the provider, the CARES Act website. We can, of course, give you that if you don't already have it. Bookmark it on your computer and make sure you continue to look for changes, because those changes have been dramatic over the last just even couple months. Okay, so we don't even know what the reporting requirements are going to be on the federal side as well. Because we have some basic parameters, but we don't have the forms or anything else like that. That won't happen until after the first part of the year. Okay, so some important things to remember. The 10% increase does not change for August to December. Jennifer went over that. We don't think it's probably going to even change for at least the first part of the subsequent year as well in 2021. It applies both to Medi-Cal fee-for-service, everything else. Okay, so now we're going to the auditing piece. We got to move along here. I guess we're getting close to time here. Okay, so now when you start looking at auditing and reporting, okay, next slide. Okay, when you start looking at it, the key dates it's going to be January 15th as the reporting system opens. That's when we suspect that the forms will be available for review. And then February 15th is the first reporting deadline, which we think probably is unrealistic given the way people have to close their books. And the final reporting deadline is July 31st, 2021. Of course, all these are as they exist today. They may change over time based upon various lobbying efforts, both at the federal level and also our own efforts with the state at the state level and how all this is going to be put together. So stay tuned. It's been a crazy year, but we understand that, and we're putting together a process to be able to educate providers as we go forward. There's also a single audit requirement. If you're over $750,000, exclude PPP, because that does not count toward the $750,000 limit. Okay, next slide. The state may require supplemental reporting. That's going to be probably a given. And the audit of the 10% required for SNFs and subacutes may also audit other providers who received increases, DDs, distinct part SNFs, and pediatric subacutes. So stay tuned. We'll make sure we keep people prepared. And we're going to have a lot of ongoing conversations with the department. We have an internal group that's working on this as well. Our first meeting with the state will occur later this month. I believe it's on the 18th, the last day of the convention, actually. And here are some important things. Just absorb this. There's a lot of people speaking on all these different subjects at this conference. And so when you start looking at it, you got the CARES Act program. That'll be Bill Ulrich and Mark Reagan. We have the Health and Human Service and Payroll Protection Program updates. That'll be Tiffany Carlin and also Greg Pfeiffer for CFO of Accounting Services. And preparing for DHCS audits, we have our resident cost report experts, in there as well. We got Mike Lesnick from Axiom, and we got Stanton Stock from Hooper Lundy and Bookman. Those are all going to be offered during this conference. We highly suggest people attend those sessions so they can go into more of a granular detail on all of this. And remember also, the recordings of all sessions will be available on December 1st. Okay, and I think that's, if we go to the next slide, I think that's the last slide. So obviously, if you have questions on all this, which I'm sure you guys will constantly have those, make sure you send those either to myself or Jennifer, and we'll do our best to try to get you the answers as we go forward. And once again, thank you guys very much for attending this session. We know it's complex, we know it's difficult, and there's a lot of detail involved, but wow, has it been quite a year for reimbursement. Thank you very much.